Hello, I'm Christopher Klein. I'm a professor of neurology at the Mayo Clinic, and it's my pleasure to present on behalf of Dr. Tatiana Faroud from the University of Indiana, a professor of medical genetics, our recent review article in the Mayo Clinic Proceedings regarding the application of next-generation sequencing in neurology and when to use NGS panels. This is one in a series of papers that are going to highlight the utilization of next-generation sequencing technology in medical science. So what is next-generation sequencing? Well, next-generation sequencing is a technology that allows for massive parallel sequencing at high throughput and low cost to provide genetic diagnosis and research discovery. So this technology has largely been afforded by the previous sequencing of the entire genome back in 2001 at a cost of about $3 billion over a 15-year period of time, whereas now we can actually sequence 50 genomes on a single instrument in a single day at a cost around $1,000 per genome. However, utilization of genome sequencing probably does not have great application in the clinics by itself. Instead, other technologies are probably more affordable and realistic, and those are the technologies of whole exome sequencing, where we're only sequencing the expressed region of the genome, which is about 1.5% of the entire genome, or even still a focused, targeted approach that looks at just the genes implicated in a specific disease entity. And that is the approach that we're favoring as our first-line approach for most of our neurologic disorders. And why? Well, we know that there's a very large genetic heterogeneity among neurologic diseases, with many genes being alone causal in a specific phenotype. And so with expert input, we can design a fairly focused panel that gets around many of the technical and ethical issues of an entire genome or an entire exome, and at a much reduced cost. So in our review article, we outline the technology, describe the basic limitations and advantages and disadvantages of the different approaches, because there still is a role for the application of whole exome sequencing in patients who have a genetic diversity that expands beyond, say, 200 to 300 genes, or where we can't actually lay down a specific localizations for a problem. So examples of that might be patients who have developmental delay with multiple organ systems potentially affected, or patients who have complex genetic disorders where we're trying to make research discovery. But in whole, we're favoring a targeted approach. And a targeted approach is really only possible by getting experts in specific disease entities that have great familiarity with the disease that can design a panel that is very appropriate for a disorder. And by doing so, we eliminate many of the problems of a larger approach. So what are those problems? Well, we realize that by doing a whole exome, we identify a large number of other genes that are not relevant to the reason our patient's coming to the office and that have ethical implications and requires a very large team approach with medical genetics and probably can only be done at a tertiary care center like the Mayo Clinic. Whereas with a targeted approach, we can focus on the disease entity that is the reason the patient is coming to our clinics. And in the interpretation phase, we can do a much better job eliminating various variants in irrelevant discovery. So, and at a much reduced cost. So we eliminate a false negative rate as well, as we know that by whole genome and whole exome, we really don't cover all the genes adequately to exclude in a disease entity those possibilities. So let me give you an example. Recently, a number of persons were sequenced using a whole genome and whole exome to realize that among those genes in a particular disease entity, there was poor coverage in at least 10% of those genes. So that would potentially lead to a report to a patient that was a false negative result. In other words, the gene abnormality was present, but we couldn't identify it by the current technology. In contrast, the targeted approach allows for a massive coverage of all regions of the genes. So when you finish the testing, you actually are certain that the genes that have been sequenced are sequenced well enough that you know that they do or don't have an abnormality within the gene. And that also has a downstream advantage in cost, but also, as I mentioned earlier, in the ethical dilemmas created by finding discoveries that are irrelevant to the reason the patient's actually coming to the clinic. So what we're talking about is integration between our clinician expert and the laboratory geneticist in creating the best testing approach. So as example, we've used this approach in neuropathy and have had great success. But that success largely depends on understanding the phenotype and even considering algorithmic approaches. So we looked at a very large cohort of inherited neuropathy patients to learn that using a comprehensive targeted approach, we could make as much as 30% success rate in a definitive diagnosis. And so that's important because a definitive diagnosis from the genetic standpoint reduces the downstream costs, expedites the diagnosis, provides patients counsel as to prognosis and course, allows for proper genetic counseling, and also increasingly gives patients the availability of considering clinical trials. And currently there are some very encouraging results among some of our most devastating neuromuscular diseases, such as spinal muscular atrophy and familial amyloid, where there looks to be promising therapies, but only in those persons where a specific genetic cause has been found. So in summary, I think that this new technology affords us a great opportunity to help our patients when we've done deep phenotyping to bend them into specific regions that a target approach can expedite a diagnosis. And I can only see this expanding across our neuromuscular field, including in inherited myopathies, congenital myasthenics, but in other areas, including central nervous system disorders where there is a very strong monogenetic cause, for instance, in epilepsy. But there will still be a role for the larger sequencing approaches, such as in developmental delay, where whole genome or whole exome sequencing may still be appropriate. So I hope you enjoy reading our paper. It's afforded a great deal of space with 14 pages, and I think this will be a great introduction to the rest of the series that will be appearing in Mayo Clinic Proceedings. Thank you very much.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.